Welcome. This is session 3C. How will developments in the biology of aging affect actuaries and actuarial practice? I want to let everybody know that the session is being recorded, so when we get to the question and answer period, it is essential for you to go to the microphones so that your question will be included in the recording, as well as for people to hear you in the room. And we'd also like to request you to identify yourself when you ask a question. We're going to start by having each panelist introduce themselves and their connection to Living to 100. And I'm Anna Rappaport, one of the people here who's been to every one of the Living to 100 sessions, and I've written many papers for Living to 100 and spoken at many sessions and been on many of the committees. So I'm delighted to see you all here and that we're having another great Living to 100. So Joseph?
All right, my name is Joseph Liu. I work for Legal in General in the United Kingdom. My connection with Living to 100 is I've not been in here every single time, but I've attended, this is my fourth Living to 100. And I have been volunteering and helping with the organization of this conference. My responsibility at work is largely to do with longevity risk over the last 15 years, specializing in pricing, getting the right life expectancy for each person, forecasting the best estimate, as well as making sure that we have sufficient money, reserves, or capital for shock, for surprises for longevity when for the purposes of capital requirement. Thank you.
Sam Gutterman. I missed the first Living to 100. I've been paying retribution for the fact that I missed that one for the last I don't know how many. But I guess one of my passions is demographic issues and demographic trends and trying to understand them. Because we are all people, and so therefore we're all both affected and affecting those trends. So therefore I think of sessions like this in terms of looking at the demographics as being very important for all actuaries. And so the deeper the understanding and the deeper of exposure to different viewpoints, I think benefits us all.
Oh, I would just add, I know that some of you are in the back. There's some chairs in the front, and I know this is not an easy room for people to see in, but so if anybody wants to come up to the front, please do. When we were talking this morning, the three of us, we realized too that we have in our work these days different perspectives and different contact. Joseph is with the insurance industry and the customers of the insurance industry people. Sam heavily with social insurance and systems, government agencies. Mine is mostly research, often with Society of Actuaries, but focused on the individual. We want to start by thinking about what we heard this morning. So we heard Dr. Horvath this morning, and Joseph, did you have any reactions or comments about what he said?
Yes, my initial reaction is that the talk is relevant to my daily work. At least it is useful for me to know what's happening in the medical field and the understanding of biology of aging and the potential of retardation of aging. I will highlight two aspects. The first is the potential, the possibility of slowing down the aging process by taking up this cocktail of pills that can improve thymus and eventually, on average, although it's based on 9 persons, on average, the age, the biological age can be reduced by 2 years over a 12-month period. So that is a potential risk for longevity. And it also provides an opportunity for us to model longevity using this scenario for stress test scenario. So that is a relevance that I find interesting for my work.
Sam?
There's the speech this morning the speech this morning brought up a number of issues that are of relevance and of interest. One of them is that was not brought up, which was healthy aging, rather than just aging and mortality. But many of the same factors that enters into the mortality also affects the morbidity. And morbidity I also think of in the aging concept or process as being caring for others and being cared for yourself. And that's some of these same factors affect healthy aging as well. This is an area that is looked at in terms of, let's say, the long-term care area, but it also leads you to the question of how much finance or how many resources are needed as you go through your life cycle, in terms of whether you're earning money from investments or consuming money from the materials or products or services that you're going to be using. And so therefore, that healthy, getting a better feel for overall your healthy or, in fact, unhealthy living periods can be very crucial. Another one is factor that I gathered was uncertainty. When I hear about the medical studies of 9 individuals, I wonder about how much certainty should I place, or the degree of certainty that I should place on medical studies. You listen to nutritional studies, and one day you think of chocolate as being really, really good for you, and hopefully those are the days where I consume more. And then next week you get that's not so important. So I think that healthy living in whatever fashion is really important no matter what. But you can't fight your genes. But genes aren't for certain. You've got being prone to get a disease. You might be able to take mitigating steps, or society can help you with the education and knowledge that you might be able to gain. Those are. I'll mention one other thing is preventive action, and it's not just in terms of the healthcare system, at least. It's not just the care that you get; it's the actions that you take to reduce or eliminate some of those actions. And so, therefore, when you think about the rapid improvement in cardiovascular disease that we've seen over the last, 50 years, even though there was a hiatus for a couple of years recently, it seems to be picking up more. But even with that lowered mortality, there is still a high percentage of people who are living with a cardiovascular event behind them, and therefore they are possibly more at risk going forward. So it's the whole process, the life cycle process that should be of concern to many actuaries.
I want to add that every Living to 100 always brings some really interesting new content, something that I wouldn't have been exposed to as an actuary, I wouldn't have thought about before. So I was really very happy to hear the conversation this morning, and I want to sort of build on what Sam said about uncertainty. We can study experience, we can do our very best job, we need to think about what's coming in the future that's going to build on the past, and the Living to 100s have helped us think about some of the biological future changes. But we can't really predict what the future is going to be, so that we do have to live within our systems with a significant amount of uncertainty. We're going to talk a little bit now about some of the different areas that actuaries work on the panel. We're going to have a break in the middle for audience participation, because we'd like this to be interactive, and then we have a little bit more content afterwards. So I'd like now to move on a little bit more. Sam, you said there wasn't any conversation about health span and healthy years. How do we see some of the biological developments affecting health insurance and health benefits?
Well, almost you name it in terms of looking at the media every day or every week, you see some new health-related issues. That affects, the healthcare system in terms of if anybody is dealing with health insurance or health provisions, significant issues that come up in terms of human behavior, in terms of medical developments, in terms of prescription drug developments, in terms of non-prescription drug developments, goes both ways, adverse and favorable. So the one question that many actuaries think about is, well, what's going to happen in the future? Well, I have no idea. Well, I have some ideas, but I have no specific or certain thoughts about what's really going to happen. So that level of uncertainty, Anna, that you mentioned is a significant issue in almost all actuarial work. So that brings up not only the uncertainty associated with the expected results, but also things like the tail. And so actuaries in there practicing work, no matter what they're doing, is you've got to look at what's the implications if blank, if it happens. And not only do you think about those one-time events, but it's the consequences of those events. That means if let's say heart disease continues to improve significantly, 3% a year, like it did in the last year, that's going to really have a significant impact in terms of at least mortality in aggregate. Or is it? If you have a significant decrease in cardiovascular, will that imply that you have more mental conditions or more exposure to cancer? And those interrelationships between those health conditions are second order, but yet very important in terms of the long-term projections.
Just I will follow up from the point of uncertainty there. In Europe, there's this requirement called Solvency II, where companies will have to hold capital for unexpected events. So that is exactly the type of uncertainty that we talk about, except that we need to quantify them and we will need to have contingency for them. The definition of Solvency II is that it's a 1 in 200 years event. So it's plausible, but we still need to allow for them. One of the challenges is to come out with these scenarios. I think for these, we need to come up with scenarios, intelligence and plausible scenarios based on medical sciences, like what you've mentioned, cardiovascular diseases, and also what these conferences is good at doing, which is bringing multidisciplinary people to come and tell us about potential impact of biological intervention of biological aging, for example. And for these, we'll need not just the plausible scenarios themselves, we also need to have models to be able to quantify what are the potential impacts on life expectancy or death rates. And with this, we need to know the potential effects of this new intervention. Is it a reduction in death rates of 10, 20%? And a second parameter that is very important, and I've been involved in discussion, is the when is it going to happen? Yep. Is this extension in life expectancy over and above what we have expected, what we projected? Will it happen today? And that is different calculations. Or is it going to happen in 10 years' time? Will this medicine take 10 years to develop?
Joseph, can I interrupt you for a minute? I know that the insurance people here are familiar with Solvency II, but we've got a variety of different people in the audience. Can you just explain to us for a minute what Solvency II is?
Solvency II is basically a regulatory regime that wants the risk managers, meaning actuaries, to quantify the tail end of the various assumptions that we use. It can be insurance. If you're selling life insurance, that will be mortality risk. What is the pandemic risk? And for those who need to have assets to back your liability, then we need to stress the interest rates risk, inflation risk, or market risk, and so on. And if we are promising to pay people for the rest of their lives, you will have longevity risk. So you need to stress that as well. Yeah?
1 in 200 years. I can think of a lot of risks that might happen in the next 200 years. And I've been dealing with the environmental area for a while, and you say, well, these 1 in 500-year storms happen to have two in the last 3 years. I got to have a new risk reassessment involved.
I spent most of my life as a retirement actuary, and one of the sad consequences for me has been that the systems that really provided people a lot of retirement security, the defined benefit plans and retiree health plans, have largely disappeared except for the public sector in the United States, and I think in many other countries as well. So that one of the big questions about uncertainty is, is it going to be the financial institutions that are bearing the risk? Are their contracts going to shift it to the customers? And what about the little guy? There's an awful lot that is on the head of the little guy.
Yes. Yeah.
I'd like to follow up on the little guy in that I look at not only the frequency and severity of these instances, but concentration, particularly on different population segments. We deal with a lot of factors, particularly those affecting lower income, and I don't know how to characterize it, but more at-risk populations, where you would think in the aggregate there's not, in terms of the likelihood of an epidemic or pandemic occurring in total, is not very big. But if you focus in on a specific population segment, whether it's the lower income individuals or those areas located in geographical areas, that you have a potentially significant concentration risk issue. Whether it be, I mean, you think about that more in terms of property insurance, but it can be just as important in some cases on life and health insurance.
Yeah. To follow up on the subsection of population, one of the things that is becoming clear is that there are differences with risk attaching to people of different ages. Longevity risk. The risk is different for someone who is 95. All this new technology, they may not eventually reach them. And there's a greater longevity risk for someone who are in their 60s or even their 40s. And the consequence of this is that when you go to the pension risk transfer market, where pension funds move their pensions and annuities commitment to insurers, so they will need to price for different group of people. So logically, it will be more expensive for the younger population because of the attaching greater longevity risk for them. So there's price differences because of age.
Who bears the risk? And you look at it in terms of somebody does or some institution does. The question is, who is it? Is it the individual? Is it the society through let's say, social insurance program? Or is it the family? Long-term care is a prime example of somebody has to provide care. Although there's certain populations where it could be done by technology, just as likely as it's being done by either paid or unpaid care. And you look at the consequences of which of those, who is bearing that risk, who is bearing those costs, and you can come up with very different answers. And the design of your system can also indicate who might be more likely to either provide that care or bear that risk, or maybe the risk is just avoided through, for example, suicide, or is it in the extreme example, or the cost of the system being, if you can't bear the cost, then the individual pays the price in some way.
Who bears the risk on institution level? Any institutions that promise to pay somebody for the rest of their lives will bear longevity risk. It could be the state pensions, or defined benefits, pension funds, they will bear the risk, and insurers that have sold annuities will have to keep that promises. And of course, every person, we had a quick chat beforehand, anyone who is retiring or living for a long time will have to bear some risk too.
And of course, in the case of the insured, depending on the situation with their capital and and guarantee funds in their country, the company could go bankrupt. So the share owners will share in the risk as well. Joseph, did you have any other comments about how life insurance and annuity product actuaries might be affected?
Will be affected by extreme longevity. Yes, the calculations, if they were to allow for this uncertainty and risk, they will have to price it in, because if we want security, making sure that we can pay people, if these scenarios were to pan out, somebody will have to put aside the money. It could either come from customers or can come from shareholders, which is the capital, or they need to find some instruments to share the risk with reinsurers or the markets. So I think there's implication on us in that we will need to understand the potential drivers. We need to potentially find ways to quantify them, model them, and accumulate sufficient asset to face these potential eventualities.
As a retirement-focused person, I want to comment on what I see as a huge issue, and one that I'm really happy came up in the second section this morning, and that's the question of retirement ages. As longevity increases as a society, we can decide, yes, we're going to adjust retirement ages, or no, we're not. There was a paper this morning about 4 countries that have tied retirement ages to life expectancy, or retiming of retirement, versus there being fixed ages, and there are issues surrounding that. But that's a huge issue tied to longevity. It's one that I feel, as the actuarial profession, we haven't done nearly enough to talk about the challenge of just ignoring the issue. And I believe that part of the reason we've had this huge trend to define contribution plans in many countries is that it's been a way to duck the issue. And I think we really need to think about that. That shift to defined contribution changes a lot. The employer plans don't really encourage retirement at a specific age anymore under those plans, but many people may reach the time that they had expected to retire without enough money. But those with long employment and generous plans for a long time should do well. Employee decisions become much more important, but employees aren't well equipped to make those decisions. Financial literacy is a huge issue. So this puts on us as actuaries that are working with the plans, we're thinking about a really different environment. We're thinking about, okay, if this thing is going to provide for people's retirement security, how is it going to work for them? What do we have to do to make it work for them? How do we help people make better decisions? What do we need to teach them? And along with that, in the United States at least, most plans don't provide for an income payout, and lump sums are common. Now in the UK, they used to have income payouts, and that's changed so much. So one of the things that I see too is that the government systems have increased in importance, but they've been very important all along. So this makes us rethink the roles of the private sector, individuals in government programs, and there are different solutions and models to look for. So I see a lot happening with retirement ages, or with retirement and longevity, and the need to face up to, okay, how do we make the system work better in light of the increasing longevity? I'd like to just also mention that the Society of Actuaries has done a lot of research that helps inform that discussion. One of the things we found is many people just aren't doing long-term planning, and that comes from the risk survey we do as well as other things. So now, we mentioned long-term care before, I think Sam did. And Sam, can you say any more about how you think the developments affect long-term care?
Well, this raises the question of the relationship between long-term care and acute care. I think that the line has always been blurred. 30 years ago, when I was first involved with skilled nursing, and therefore the individuals, when they got to the stage in their life when they needed care, they went to a nursing home. But now the answers are not as black and white anymore, because more people are looking toward assisted living, home care, community care, and those, with one respect, they're responsive to the change in needs, but also a change in the cost structure. And so, therefore, when we look at risk, we also have to look at cost. In terms of the contingencies involved, one of the big contingencies is a change in the cost of care. Significant. As the demographics have changed, the usage of long-term care facilities or long-term care or support, as now it's called in the U.S., those support services are increasing in terms of utilization, although the care in a nursing home has in fact decreased. So you're getting a whole change in the structure of the system, but also you get a change in the structure of the payment patterns and who pays and how it's paid for, how it's provided. So you're having fundamental challenges, and certainly, like decades ago when I first studied long-term care, the projection was, the real challenge and the emergency is going to happen in the early 30s to 2030s. And you know what? Right now, I'd say the same exact thing in the U.S. and in many other countries, that it's going to hit in 10, 15 years in. The U.S. as a society isn't prepared for that. U.S. actuaries aren't aware of what the mortality rates are going to be in the age 90s. But right now, all we know is that there is going to be a risk, and the risk is going to be borne by someone. And how it's going to be borne, who's going to be borne, is to some extent something that I've been wanting to mention, which is political risk. And political risk is something on the societal programs is significant. And in fact, it's even significant in the private institutions when what happens if a financial institution goes belly up or goes bankrupt. Who bears that risk? And who bears the costs associated with that? So therefore, those issues are significant ones going forward.
I just want to alert you that we're going to have just a little bit more panel discussion right now, and then we're ready for your comments about what you heard this morning and about any of these effects on actuaries. So get your questions and comments ready.
Yeah, just two more comments before we move on to that. I look forward to hearing your views too. With regards to long-term care, I think the outcome depends a lot on how longevity and healthy life expectancy interact. If we are living longer, but longer with diseases and disability, and then the cost for long-term care is going to be to increase. But if we are increasing healthy life expectancy, and then the scenario will be different. But second notion that I'd like to probably get your view is there a potential for asymmetry of information? If I can test my gene, this morning we heard about that genetic is important. Is there a risk that people test their genes and found out, oh no, I've got this super centenarian features, and they start buying annuities? Just pose this question to everybody.
And I just want to make one more comment about long-term care. There are huge issues in the U.S. Even today, there are issues about caregivers, but as Sam points out, going forward, it's not just long-term care issues go way beyond financing. Who's going to provide the care? How are we going to pay for it? Where is it going to be? How is this all going to work? And I would say, as actuaries, I think we have a tremendous opportunity to get much more involved in thinking about these big societal issues and in bringing our perspective into conversations with other groups in the community, because so often the people that might be discussing these issues, they don't have long-term perspective, they don't have some of the underlying skill sets to think about these issues more broadly and more longer term. So I'm going to open it up at this point for questions, and then we'll have a little bit more interactive panel after some questions and comments from the audience. Please come to the microphone and identify yourself. Do we have anybody want to comment about their takeaways from Dr. Horvath this morning?
Hi, Rob Brown. I guess in the context of Monty Python, I'm going to go a completely different direction here. You've got, in a DC world, you've kind of got two choices at the moment, as I see it. You can buy an annuity from a life insurance company, or you can plan your own drawdowns. Annuities are expensive for a lot of good reasons. There's anti-selection, there's Solvency II, there's the cost of capital, there's profits, there's commissions. The drawdown, the problems there, I think, are pretty obvious. No one person knows how long they're going to live. So it seems to me there's a third vehicle that we, as an actuarial community, should be thinking about, if not promoting. And that is a cooperative asset pool, where you go in there with a few thousand people, a couple of thousand would be enough, and your payout is not guaranteed. It's doubly variable. It's variable as you think of variable annuities with the rate of return on the assets, but it's also variable with longevity. So I would rather have that as my option than a for-profit annuity or do it yourself as one person. The longevity risk is easy. You've got a couple of thousand people. You can handle the variation in longevity. The volatility will be in the investment returns. But I haven't heard the actuarial community talking about this, and I certainly haven't heard the actuarial community promoting this.
Hi, Eric Pickett from Club Vita. I think that's a tontine.
Can you get to the microphone? Yes, please.
Hello.
Yeah.
Is that okay? So I think that product's a tontine, and I think there's been some work being done on it at the moment. There were certainly some talks at the last Society of Actuaries annual meeting on that. I think they fell out of favour when there was rumours of people finding out who the other 1,000 people were and not acting in a great way. Yeah, but I think that's a really interesting point. But I think there's another issue, another option as well, maybe of deferring your annuity. I mean, a tontine still doesn't get rid of your trend risk; it gets rid of your idiosyncratic risk, I think. So you might still want to cover the trend bit of it. I always think that deferring the annuity. I mean, you want to cover your tail events with your annuity. So maybe defer the annuity till later on in life, so 80, 90. Manage your own portfolio until then, and then get a sort of annuity portion to cover that tail risk part. Feels like a really good solution to me as well. That's my comment.
Asibilik, and actually Eric stole my thunder. I was going to talk about longevity pensions. So, and in Canada, they ran at some point an idea about having in one of our provinces longevity pension, the one which was starting, I think, 75. Unfortunately, the idea didn't fly, but recently I know that World Bank is starting to promote this in many countries, in Eastern European countries. And talking about longevity pension, you don't even need to go on the DC basis. You can go on the defined benefit basis with some kind of a payout in the case the person doesn't survive to the age. Anyway, thank you.
I want to add to the payout discussion of what I think is a really interesting thing. As actuaries, we normally think about people are going to get to retirement, they're going to have a pool of assets, and they have to decide how they're going to use it over the long run. Are they going to buy an annuity? Would they go into such an arrangement? Well, when we ask people in the post-retirement risk surveys about what they want to do, they tell us, no, you don't have it right. We want to keep the assets. We don't want to spend them down. And this is a really interesting aspect of it. And we've heard this now repeatedly in several sets of focus groups and risk surveys. I've had some conversations with people that indicate that there's maybe similar issues in the UK, Australia, and other places, and that the retirees really want to, and the retirees furthermore in terms of we want to keep the assets and we're willing to make significant cuts in spending to do that, and they're quite frugal, and there's evidence apparently from multiple countries that people are spending less than they might, but also, I mean, it's a choice. So as we think about this, we might want to add this into the equation. And I want to say that the Society of Actuaries has done now risk surveys since 2001 every 2 years, several focus groups with people retired less than 10 years, more than 15 years, research on people over age 85, which we will be presenting at the next session. But one of the things that's happened as a result of this is that we've come to realize that what we think people believe and what we think about how they might act and what people believe and how they might act is not the same thing. It's important for us to start to focus on that. So that's just another factor to show into that conversation. I didn't hear from any of you any comments about the biology or Dr. Horvath, the presentation this morning, and the comments were mostly about pensions. So we have a comment here? Do we have a comment?
Well, just one quick additional issue is I don't know whether or not we've settled on the ultimate definition of what retirement means. And I don't think we know for certain what all of our needs will be, as Anna just mentioned, in terms of our needs with respect to work.
I'm going to definitively answer your question, Sam, to say we haven't, that increasingly work is becoming part of retirement. We have a project where we're working on that. We have Les, and we have somebody over here who wanted to make a comment. So maybe Les first, and then you second.
Thanks very much, Les Lohman. I think that health actuaries need to get involved in looking at the data of chronically disabled, non-infectious disease young people and how that's going to affect. The earlier session we talked about, the participation in employment that's so important in the dependency ratio. And, if we really are facing some very serious issues. In the 50s, we didn't have anybody that had autism. And now we've got some ridiculous percentages. I unfortunately haven't memorized them, but, it is significant. And apparently, according to the CDC and others, increasing. And so, somebody needs to be looking at that data in an intelligent way that has actuarial skills and looking at how it's going to affect funding, social programs, and things of that nature.
Thank you. Stephen Baxter from Club Theta. I'll try and rise to the challenge of bringing it back to the biology of aging talk from this morning. In many ways, I wonder if the discussion we heard this morning around the epigenetic clock is just one of the clues of the work that's going on that's helping us understand vastly more about the biology of aging. And as such, it's maybe an early warning indicator that actually the world in 10, 20, 30 years' time, in terms of how long we may live for and how the needs of the consumers that the actuarial profession services may dramatically change. And I think with the retirement planning discussion we were just having, that was perhaps an example of that. That if we think about the work of Linda Grattan and Andrew Scott when they talk about the 100-year life, how we may have increasingly a different notion of what work looks like, what retirement work looks like, how we go through phases of our life, and therefore how our needs from financial products, insurance and pensions provisions might change. And actually whether or not it's a signal to us as to actually the need to start to think ahead and think about the innovation and product needs of the future. How do we allow for the inheritance motivation that many people have? How do we allow for the flexibilities that people want as they transition towards retirement to maybe work less hours but still have a certain level of continuity of income? How do we ensure that that individuals can have some certainty around their care provision in later life? So if they are unfortunate enough to enter the morbidity stage rather than the mortality stage, or fortunate enough in terms of having the life years, but unfortunate in terms of the consequences, how do they know they'll have a good quality of life? But how at the end of it do we still have the traditional products, like the annuity, that ensure the convenience motivation? That point when perhaps we are still perhaps unable to deal with some of the degenerative diseases of the mind, and we no longer want to deal with our matters, our financial matters, our complex legal matters, that we know it has been well established, it's been well served, there's frameworks in place that mean we have an annuity, we have whatever those other frameworks are, that we can rest in peace, as it were, for our last few years before we terminally rest in peace. Thank you.
Okay, I'm going to now move on to, we have some additional questions for the panel. How do we communicate with users and stakeholders about these issues, and what are some tips particularly to actuaries about communicating effectively? Because we don't always use the same language that the people we deal with do. Joseph?
Well, this is from my experience with senior management and non-executive directors. I find that they are interested in general scientific background of these interventions. They don't like us saying, well, we just live longer. Why? We just live longer. They like to understand there are some drivers behind it. It could be the biology of aging that we mentioned. It could be potential medical intervention in terms of medicine and surgery, or it could be the drivers from improvement in healthcare systems where things become more effective, where medicine can reach us more effectively and efficiently, or they would also like us to know that we understand the potential trend of risk factors like alcohol uptake that Sam mentioned, or smoking trends and their potential and their relationship with mortality. So I think to communicate well, we need to have a good vocabulary that is related to medical sciences and epidemiology and public health to make us credible, that we know what we're doing. It's not just numbers coming out of thin air. We also need to have a good understanding of consensus and differences among the medical people. So you may have a group of people who say that, yes, we're going to live to 1,000. The first person to live to 1,000 is walking among us, is sitting here. And then there's another group that says that, no, that's not happening. We know that we can modify biology of aging, but at the moment it's largely through exercise and diets and so on. It's not silver bullets. So we need to know the differences in views as well as consensus within the scientific sphere. I believe that they also would like to know some potential impacts, the possible scenarios where people might live for 2, 3, or 4 years longer, and the likelihood of that from happening, and when might that happen. So in summary, to communicate with them, I believe that we need to have a good grasp of what's happening around us, have a good grasp of data and statistics, and then think about using languages that can connect with people.
I think that the answer to every question is often more education. But unfortunately, more education is not necessarily good. It's more effective education, and that is really challenging. I mean, the question, and it ranges from why is, at least in North America, why is the take-up of annuities, that's payout annuities, why is that take-up so low in view of the longevity risks that many of us will face? Why is it that even though you've got some percentage of the population that does appropriate or planning, there's a huge percentage that does not. And in some cases they cannot, and in other cases it's just inconvenient to have to think about savings. And I'll even think about the problem of management of debt. We think about the huge percentage of people who basically have negative net worths, and let alone zero. Those that have negative net worths, and the concern about what happens on inheritance when you inherit a debt. I don't think enough people have thought about that, and I think that it's something that in terms of communicating the simple issues, the simple ideas, are the challenge. It's not so much my complex paper. I mean, not many people are going to read that. Hopefully, all you will, of course. But the general population, or those who are significantly affected by the lack of the coverage of their longevity risks, you've got to have something that's much more simple, something that people in different population segments will be able to actually be interested or be willing, even if they don't want to, or leave it to their spouse to be able to balance their checkbook because they don't want to, they don't like to, and they don't think they need to do it. You all of a sudden think of if you departner, at some point in time, the person is going to get stuck, and that population segment, and you name it, you can figure it out just as well as I can. The lack of the financial literacy, financial education for the simple but extremely important issues are something that's a societal challenge.
I think when we're thinking about communication, too, we need to remember about helping people that they can't deal with a lot all at once. We need to think about one issue or two issues at a time, and I'm going back to the risk survey and the need to get people to think longer term. I think that's really critical. I mean, Joseph says, well, it might be 2 years longer, but if we're not thinking longer term, one of the scary things that we found in our focus groups, and we found in repeated studies, that people think of planning, some of them, in terms of, well, if I can pay my bills this year, I have these bills, my regular monthly bills, and if I can pay my bills, I'm probably okay. They didn't think about the fact that they may have to go to the dentist and have a big dentist bill, or they might have to fix their roof. But if I can pay the regular monthly bills. So there is a lot of gap in getting people started on a track to think about things where then they can incorporate the longevity into it. So do we have any suggestions about how actuaries can use these developments in their practices and reflect them? Where do they start in being able to grab onto this? Do you have this? Here's my actuarial practice and the things I regularly do. Here's all this important stuff, and I should migrate it over. How do I make that happen? Joseph, do you have any suggestions for us?
I think to do that, we need to have a better view of understanding of behavioral sciences. I don't have the answer to that, but I'd like to highlight some issues that we have come across. In the UK, we used to have all DC savings will have to buy annuities, but since 2014, that was no longer the case. We call it pension freedom. And following that, there was a website by the government that helped people plan their retirement. And with that, there's a life expectancy calculator. So you put in your age, and then here's your life expectancy. And there's a new research that found that people who use that life expectancy calculator tend to be less likely to buy annuities. And one of the hypotheses is that it scares people off when people have to think about their death. Oh no, I'm going to die. I have to, in X number of years, and that shut people out from making decisions, and then they just take the money away. I think we need to understand all these intricacies and people's feeling when they are making decisions like that, and find ways to frame them in a way that so that people do not make disproportionate or decisions that they might otherwise regret.
We have a comment from the floor.
Hi, yeah. So I share the idea that the communication is really centrally important for us. We actually ran a webinar just before Christmas tackling some of these issues. It's just a quick advert. It's available on the Club Vita website if you want to check it out. But the behavioural aspects I think are really interesting. One proposition was that due to the availability heuristic, the idea that we value things that we can draw to mind much more quickly, that's leading to people to underestimate their life expectancy. There's a lot published about celebrities who die very early, and that makes stunning headlines. But because that's in the news much more often than the story about someone living to a very long age, then people think about it a bit more. So I think embracing these kind of behavioural finance things and trying to work with nudges rather than, as Sam said, the education is really good in theory, but it doesn't seem to work all the time. So applying some sort of nudges to get people into thinking about how long they might live is really important, I think.
I spent a decade in charge of a marketing research department, and a few things I learned was, one of the things I learned is you gotta be able to understand the needs and the reactions of people involved. And I think the Retirement Needs Committee of the SOA has been doing a really great job at trying to get at those and better understanding those needs. I think we got to take the next step, though, is in terms of what do we do with it once we understand some of these issues. What are some of the either program design, product design, marketing or outreach design that's needed?
Jochen Roos, Ulm University. I would like to comment on what you just said, Joseph. I also spent quite some time applying insights from behavioral economics to questions of insurance demand. And we had the very same situation in Germany, where such a life expectancy calculator actually reduced sales of an annuity. And our hypothesis was a different one than yours. Okay. Our hypothesis was, if you show people their life expectancy, that suggests to them that there is a certainty. Just plan your assets with regular drawdowns until your life expectancy, and you have a good solution. Yeah. So what we then did is we changed that calculator. Now it doesn't say your life expectancy is age X. It says you have a 50% chance of living to this age, a 20% chance of living to that age, and a 10% chance of living to that age, which suggests that there is uncertainty. And if you have uncertainty in the back of your head, of course, you go to insurance that creates certainty or safety, and they increased the sales of annuity once they switched their calculator from a life expectancy to certain percentages.
Thank you. Very interesting.
That's what the Society of Actuaries, Academy of Actuaries calculator does, is to look at raises those probabilities to the fore. The question is how do you use it? And how do you interpret it, and how do you get people to actually pay attention?
And that calculator that Sam just mentioned is the Actuaries Longevity Illustrator.
For people to make decisions, I think it's very important to have complete and total information from what they expect from different sources. And let's talk about retirement. I used to be a retirement actuary, and I'm a social security actuary. And I saw in many European countries, they created a centralized platform which is able to collect the information for individuals from all sources of retirement. Social security, private savings, the employer-sponsored pension plans. So as a result, when the person is going to this type of platform and looks at, has much clearer picture what can he expect and how to plan its retirement. So this is my first point. And I know, like in North America, I don't know about US and Canada, there is a lot of issues about the privacy of data, and this is something that impede this type of project. But I think this is definitely one way to go, to have like a centralized hub where you can go and look at your future finances. And of course, it can involve illustrations of uncertainty. This is my first point. The second point, it's I think one of the part of the communication is just to give people incentive to save. And I think it's really high time for us to stop called pension contribution taxes. Because when we call it taxes, people are saying, okay, we pay it, it's gone, we don't know what it. But if you really call it pension savings, it gives people much more certainty that they really will be used for your retirement. Thank you.
Doug Andrews, University of Waterloo. While I found this session very interesting and as advertised, it doesn't seem to tie as much to the biology of aging as I thought that it might. And so I've been thinking what a session might be like that did that. And one of the things that Sam mentioned earlier on was perhaps we'll eliminate certain diseases and so on, and so we'll live longer. And then he said, but maybe we won't. I mean, what about mental illnesses and so on? And we are continuing to see increases in mental illness. So there's a biological aspect. But I'd be interested to hear about all the different ways in which that might affect actuaries. And I've started to think of a list. So surely it affects communication. If you're communicating with a population that you're no longer thinking of as necessarily reflecting normal behavioral characteristics or rational man design, how do you communicate? If mental illness becomes increasingly widespread, then there becomes protection for the public. So will we allow insurance companies to gather all the kinds of information that they now do in order to underwrite, or will we force underwriting issues to change? It affects, mortality, it affects morbidity. So there's quite a large range of things. I'd be interested in your comments.
Thank you very much for that comment, Doug. And that gets me to another question that I really am interested in hearing from people about. What suggestion, all of this, and we didn't talk as much about the biology, and I was hoping we'd hear more also. What does all of this suggest about ideas for future research for the actuarial profession? I'm going to start with us on the panel and then open that up to you all. And to the extent we have remaining time, we'll have a few more questions. Sam?
I think we have to do a better job at dealing with uncertainty and dealing with education. Uncertainty is understanding what types of tail risks we have. We as a support to other financial institutions, financial programs, in terms of not just dealing with just expected values. We have to deal with how to communicate uncertainty, how to quantify it, and how to deal on a contingent basis with it, which leads me to the question of mitigation. How do we try to reduce the number of people who are suffering mental diseases? So I think, or mental conditions. I think some of it is in the works. The biologists, those who are looking at psychology, are looking at it. But I think in terms of how do you mitigate, encouraging community support is one of the key factors in terms of getting people to talk to each other. How to get people more to interact, which improves mortality and reduces the likelihood, even though it's a small reduction in terms of onset of mental conditions or adverse mental conditions. So I think the research is really better understanding of the issues of both demand and supply, and how, if anything, society can better mitigate either the onset, the management, or delivery of care. And I think that some of those actuaries can at least participate in, if not in a few cases lead, particularly the financial effects of these conditions.
Yes, I think just addressing your question about biology and actuaries, I think what we can work more closely interdisciplinary among biologists, medicine, public health, and actuaries is to understand the potential drivers of longevity or reduction in mortality, and how do we model for them to affect the general population. So we need to be able to understand what's in the test tube, in the experimental stages, and what is in the animal experiments before any drugs that come to us and need to go through that phase, and then what's in the clinical phases. And eventually we also need to know how are we going to get that. Suppose I've got something that can reduce or death rates by 20% here, and how is it going to reach the people in the population? I need to market it, there will be a time lag, and then there's an uptake rate. Not everybody might take it. And following people who take my medicine, there will be a failure rate. People may forget about them. So there are all these different steps. There are well-studied medical literature that look at uptake of technology. Some technology may take 20 years to eventually disseminate it in the population, like statins is an example. And even that, not everybody who needs them take them. Only 80% of people who need them have it. And those who have them, not all of them take them on a regular basis. And therefore, the effect on the population is different. I think that is an area, a research area that we can work together between actuaries and other disciplines.
I'd like to suggest that we do more work on the issues of risk sharing and long-term guarantees. With my years both in insurance and then many years in the retirement system, long-term guarantees seemed they were very much a part of what we were able to do in financial systems, where people could enter into a contract and expect something to last for a long time. Now, sure, some of the insurance contracts were participating, which meant that the person who bought it paid a higher price, and if things went well, they got a reduction. If things didn't go well, they paid the higher price. But long-term guarantees were part of the deal, and to a large extent, they're much less available now, and I worry about their future. And I feel it in the whole issue, too much risk has been shifted to the individual. So I'd like to see us really working on what long-term care, given that we know that longevity is improving somewhat and uncertain, and that a long-term guarantee, even if it's not a complete long-term guarantee, even if it's a partial long-term guarantee, can be very valuable. What can we do in the areas of risk sharing and long-term guarantees? Those are my two. I'd like to hear from some of you if you have ideas for future research and what we should be thinking about this.
While you're thinking about your answers, I share your concern about long-term, just like we've seen in the interest rates environment of, we used to talk about the catastrophic event being a Japanese scenario, which is low interest rates for 10 or 20 years. Well, geez, we're here. How much longer it's going to happen, I don't know. But then you try to look at the same types of scenarios on the biological side. What happens if we are, and I go look at both ways. We are going to continue increasing mortality improvement by 3% on the one hand, or maybe we'll come up with 0% improvement. I mean, both types of scenarios will develop challenges to different either financial institutions or programs. Yeah, great.
Sorry. Laura Curtis from University of Waterloo. I'm not an actuarial, I'm an economist, and I've been going to these sessions and I keep thinking, we're talking about sort of people investing sort of long off, but we're not thinking about their situations now. So you sort of suggested debt ratios. There's a lot of, the middle class is shrinking, the very upper class is growing. So there's a lot of people don't have any funds to invest now for their future. And it's kind of, I don't hear any thinking about that going on.
René Delsan, University of Quebec at Montreal. I think as actuaries, we have to look at all the consequences on the people, on the society, and including economic consequences. Should we at some point say, maybe one thing we should consider is to help people to die? At some point, it's over. And for all of us who know people that have really heavy cognitive disease, maybe it's the best solution for the society as a whole and for the people. And as actuaries, we can show what are the financial consequences if we support all the people that have all these mental disease, or maybe to recommend that at some point we should help the people to die.
Yeah, Les Lohman again. I think that was an Australian accent, to die. But in any event, that brings up an issue that always bothers me, which is that as actuaries, we say we believe in a free market. We certainly want freedom of choice of our own choices. And yet, I constantly see us using our intellect and our intelligence to lead toward imposing ideas and actions on publics, our publics, against culture, against traditions of things. I've always been bothered as a retirement guy on this concept that people shouldn't be able to take a lump sum out of their defined contribution plan because we decided it's better if they get an annuity. And I can't. I think that as actuaries, when we're considering everything, we should consider the rights and traditions and the culture within which we're dealing, and to suggest that we're smart enough to tell an individual how he should use his assets or her assets or its assets. Thank God we're not in Canada. I'd be in trouble. I think is arrogant beyond conception. So in any event, I think we should be considerate of all of the factors that enter into what we're doing, and in particular, our traditions, our culture, our legal history, and things of that nature, because it's going away. So thanks.
I won't respond directly to the why don't we the death question, but yet on the other hand, 30 years ago, I'm not certain we would have all accepted some of the practices of the hospice industry. That is all of a sudden shrinking the number of meds that somebody takes. So even though I think society with a little s will challenge many answers to that question, I think that it's a useful question at least to think about to raise your awareness of some of the issues involved.
We are almost at time, so I think I'm going to ask the panelists If anybody, I'm going to ask the panelists for a closing comment, and if anybody else wants to make a closing comment, we'll have time for one or two. So, Joseph, do you have any closing comment you'd like to make?
Yes, I think the development of biology aging and also the drivers of longevity has prompted many socioeconomic issues that in turn is being discussed here. It just shows there's quite a wide and far-ranging effects on many people internationally. I think we need to continue to move on the dialogue, to keep talking, and to really eventually help different countries and different societies to pave a path to overcome some of these challenges.
I have lots of possible last observations, but one of them is that the actuaries, in terms of practice, have got to look not only to the benefit of the institution or program that they're looking for, but also looking at the benefits of society, and that implies better understanding the society's needs and methods of either satisfying them or mitigating the cost. Since we're in the ball game of attempting to satisfy, bottom line anyway, satisfy society's or members of society's needs, I think that we need to look at and continue to examine what are those underlying needs and what are how to help the program. Like in terms of the ESG concept, the environment, social, and governance disclosures. Although focus has generally been on the E for environment, I also look at it in terms of S for society and the ability of our institutions that we provide service to try to address better society's needs and how you can do that. In some cases, it's really challenging, but in other areas, I think it's a challenge to the actuaries to be able to get the services that are provided to better address those fundamental societal needs.
Well, I've been an actuary more than 50 years now, and sort of every time maybe you think, well, okay, I understand what's going on. Something pretty major happens, and there's always the next change, and sometimes it can be pretty overwhelming. There are a lot of really interesting things involved. We sort of touched on with mental illness, cognitive decline. I mean, that's another part of this issue. There are just so many challenges for us. I'm happy that we're here to talk about them, and I'm also happy that the Society of Actuaries has been doing some broader research, but I think this raises the issue that we need to continue to broaden our horizons and adapt to what's going on around us as we continue to try to help these financial systems. And they certainly need us in the future. The systems have certainly had a lot of stresses, and there's a lot of opportunity for us. So with that, if we have one or two more closing comments, we'll take them. If not, we'll send you along, and I'll be back for the age 85 and over session at the next session. Thank you.